Hello, and welcome to the training course for Prevention, Identification, and Management of Infections in Health Workers in the context of COVID-19. This course will provide an overview of infection prevention and control strategies to reduce and manage SARS-CoV-2 infections in health workers. It is intended for infection prevention and control focal persons, occupational health service providers, and health managers or administrators, and is based on the WHO guidance document Prevention, Identification, and Management of Health Worker Infection in the Context of COVID-19. There are 3 short modules in this course covering the epidemiology and risk factors of SARS-CoV-2 in health workers, screening health workers for SARS-CoV-2, assessing and managing health worker exposures and infections, and safe return to work after infection with SARS-CoV-2. Please take a moment to read the objectives for these modules listed on this slide. This is the first module in the course. In this module, we will examine the epidemiology and risk factors associated with health worker infections in the context of the SARS-CoV-2 pandemic. Throughout this pandemic, health workers have been at higher risk of being infected with SARS-CoV-2 than the general population. Data collected globally by the World Health Organization through the Case Report Form System, or CRF, has shown early in the pandemic health worker infections represented just over 10% of reported cases of SARS-CoV-2. By early June, health worker infections had declined to less than 5% of infections, and subsequently to 2.5% by September 2020. It is important to mention that this information is based on case report form data provided to WHO, which has limitations, mainly due to variations in reporting coverage and completeness, reporting methods, some irregularity of weekly reports, health worker definitions, and lack of information about the setting of exposure. Country-specific trends for health worker infections remain highly variable. It is difficult to reliably compare incidents of health worker infections over time, and trends should be interpreted with caution. Additionally, it is not possible to determine the place of exposure among health workers from the WHO CFR data, such as healthcare facility versus community. I would like to point out that WHO defines a health worker as all people engaged in actions with the primary intent of enhancing health, including social care workers who often have roles in the provision of care in long-term care facilities and in community settings. The incidence of SARS-CoV-2 infection, PCR positive, varies widely ranging from 0.4% to 49.6%, and the prevalence of SARS-CoV-2 seropositivity ranged from 1.6% to 31.6% amongst health workers on the study. The International Council of Nurses conducted a survey of 50 countries, mostly from Europe and the Americas, and found that health worker infections ranged from 1 to 32% of all confirmed SARS-CoV-2 cases. Understanding the data about health worker infections, risk factors, and how transmission happens can help health facilities implement measures to prevent further transmission and create a safe environment for health workers to deliver care to all patients. Transmission of SARS-CoV-2 happens between patients and health workers, residents in long-term care settings, and also potentially is associated with exposures to infected coworkers. Infections among health workers may lead to a depleted workforce during a time when the demand on the healthcare system has increased. In addition, health workers who are infected are at risk of transmitting SARS-CoV-2 virus to others in households and other community settings. In April of 2020, WHO commissioned a living rapid review of published literature to identify risk factors associated with health worker infections, which is updated regularly. Risk factors that have been highlighted include performing high-risk procedures such as intubations, direct contact with patients and patient bodily secretions, inconsistent infection prevention and control practices such as improper use of personal protective equipment, and suboptimal hand hygiene before or after patient contact have also been identified as risk factors contributing to infections. Exposures have occurred in the community outside of work as well as in the workplace in common areas such as break rooms, cafeterias, and other places where health workers may gather with colleagues. Recently, it has also been noted that health workers of Black, Hispanic, or Asian race or ethnicity, in particular in the US and UK, have an increased risk of SARS-CoV-2 infection. Although there are risks for health workers, health facilities can put measures in place to mitigate these risks. For example, the WHO Living Rapid Review had identified that appropriate personal protective equipment use, hand hygiene best practices, implementation of universal masking policies in healthcare facilities, and adequate infection prevention and control training and education for all health workers are associated with decreased risk of infection in health workers. Adequate social health protection measures, such as health monitoring, sick leave for quarantine, and stay home if unwell policies, can also contribute to prevention of infections. Therefore, WHO recommends the establishment of national infection prevention and control and occupational health services programs at the national and healthcare facility level. Additional measures include implementing a surveillance process for symptoms of SARS-CoV-2 in health workers and strategy for testing for early detection of SARS-CoV-2. A blame-free process should be in place for health workers to report occupational and non-occupational exposures, as well as management of health worker exposures and infections. Data should be collected and analysis on health worker infections to improve prevention measures. This brings us to the end of the first module. The following modules will examine these recommended measures in more detail.